Now we will talk about what the best way could be to change health behavior. What are the possibilities? What are the main challenges? And we will talk about smoking. Lifestyle is said to be responsible for around 30% of all cancer cases, and smoking or tobacco alone may explain about 20%. So how do we change? How do we change lifestyle for people? Should the individual have the main responsibility, or should politician, governance make the difference? We will discuss this. We have asked our panelists to start with a short introduction of 6 minutes each, and then we will have a discussion that I hope will involve all of you. So, our first speaker, Dr. Vinayak Mohan Prasad, is a physician by training, and is a physician by training, and today a program manager for the Tobacco-Free Initiative in the Department of Prevention of Non-Communicable Diseases in WHO headquarters in Geneva. A very long introduction. Please welcome Dr. Vinayak Mohan Prasad.
Thank you and good afternoon. Make it simple. I was asked to speak on governance of behavior, and I don't think it's really separable. And I think the most critical for us to figure out is where do we start when the world of tobacco control, and which you rightly said is one of the biggest causes of preventable cause of death. So those are some basic numbers which we should remind ourselves. We have 1.4 billion, that's 20% of the world. 1 billion smokers and 400 million, almost 400 million smokeless. Some of it is not documented at the moment. Officially, it's 346. And then out of the 8.8 million, we have about 22% attributable to tobacco. Most interesting, and this I want to highlight here, is many of the oncologists don't even tell their patients to stop smoking, even once diagnosed. So for lung cancer cases, we have just documented this. More than 50% of doctors actually don't tell the patients to stop smoking. So is that a governance issue? Is that a behavior change issue amongst doctors? We need to figure that out. Why do we need governance? Because tobacco industry doesn't have boundaries. We have our own boundaries here in Sweden or Switzerland or India. So it's all global. And therefore, in WHO, in the world of health, there's only one global treaty, the Framework Convention on Tobacco Control. And then we have global commitments, whether it's under non-communicable diseases. Even SDGs now have one tobacco-specific target, accelerating implementing the treaty. And it's important to remind ourselves that governments now recognize that this is a global challenge. But nationally, we need to make progress. And the most critical is that we need governments as a whole of government approach. So behavior of individuals, behavior at the government level, but also the tobacco industry. That's the elephant in the room, which has a very unique behavior patterns. So the Framework Convention, 181 parties, hugely empowering for countries because it's a global commitment. And then WHO brought out some of the best elements of that into highest level of implement, warning labels, raising taxes. Many of the countries have achieved progress. And I'm just giving as a reflection, some of these countries, I mean, Uruguay is my favorite. No other countries achieved that kind of reduction in targets over the last 10 years, 15 years, in terms of global commitment and reduction. But you can see a huge mix. But then there are countries which haven't made progress. They have signed off on the treaty, but they haven't made progress. So we have Indonesia, many of the Middle Eastern countries actually seeing an increase. We have women tobacco use going down all over the world, achieving targets, except one part of the world. Guess where? In the European context. And it's not Sweden, it's not Norway, it's not France, but there are many countries here in the European context which are actually seeing an increase in women tobacco use, something to debate. When the African women are seeing a decline, why is it the Eastern European women are seeing an increase that will beat the targets going up? All right, so behavior change. I talked about possibility of individual behavior change. That's extremely critical. Brief advice, what does it cost doctors and physicians and health workers to provide this? And it's the most effective to provide brief advice, put it as part of the health program. We have evidence of its effectiveness at all programs in developing countries, in developed world settings. This is a new summary document which we are just releasing with IARC on how the knowledge amongst health workers and physicians is so limited in terms of providing that advice. And I hope that will be useful to make some of the recommendations work. Does it cost money to put toll-free quit lines? Does it cost money to put mobile programs? You've launched in 5 countries mobile cessation programs, how to help people quit. In India, for example, 2 million registered last year, 7% quit successes, which is quite impressive. So these are all the documented evidences for individual behavior change. But then government needs to also have a behavior change. Governments think there is money out there, there's economic development, there's farmers, tobacco-growing farmers, there's tax coming in. But the burden far exceeds what is being generated in most countries of the world, except perhaps Malawi and Zimbabwe. So it's very important to walk the talk as a whole of government. The industry behavior is so critical. It's needed to see how industry for years have misled the governments, misled the public. The Truth Initiative in the US, most recently they've been asked to run campaigns that they told a lie in the US. And they're reinventing themselves. New products called smokeless tobacco, which is basically cigarettes which do not show smoking. That's in 36 countries already introduced. So we really need to take some closer look at the tobacco industry investments and how the physicians, the public health people could actually look at the industry tactics so that the governments are not misled. Thank you.
Thank you, Vinayak. We have to take a closer look at the tobacco industry as well. The next speaker is something of a living legend in Sweden. She's been a parliamentarian member of the Swedish Parliament, Liberal Party, since 1988, with a short break till now. She's the previous director for the National Board of Health and Welfare in Sweden, and she is also a medical doctor by training.
Yeah.
Very welcome, Barbro Westerholm.
Thank you. My first meeting with the tobacco question was around 1960, when I was a young doctor in the Department of Lung or Thoracic Medicine at the Karolinska Hospital. In that ward, about half of the patients suffered from tuberculosis, and the other half, most of them physicians, suffered from lung cancer and died there. Shortly after that, Sir Richard Doll's study on lung cancer in British physicians was published, and it was much debated, questioned, could it be right? But physicians, very many, took it seriously, and today about 2% of the Swedish physicians smoke, and they are very old, most of them. The next time I met the question was when I was in research on the adverse effects of oral contraceptives. And it was found that in women who used oral contraceptives and smoked, they had a higher risk of arterial thromboembolic disease. And that started to wake up both physicians and the population, especially women, and politicians. But not very much happened. What happened was actually that pregnant women were advised not to smoke. And that was because we had made a wide, real survey, I think including some 35,000 women in healthcare, where we suspected a soup was the cause of malformation and premature birth of the children. But it turned up it was smoking. It happened in the smoking women. So then government got interested that at least during maternity pregnancy, women should be advised not to smoke, and money was put into education of midwives, and there was a group with journalists also pointing at this risk. So there was quite a decrease of smoking among women. At the same time, the National Board of Health and Welfare, which was then responsible for preventive health and promoting health and so on, started to investigate how should we, by different measures, reduce smoking in the population. And when I was there in 79 to 85, it turned up that we should higher the taxes. There was a need of legislation to guarantee smoke-free workplaces and so on and so forth. But government didn't listen, thought it was to intervene in the freedom of people to choose their own lifestyles. And this was among both the Conservative parties, Liberal Party, Social Democratic Party. But one thing happened in the early 80s in Parliament. Social Democrat Margareta Winberg said, we have to unite women in Parliament to get a legislation against tobacco, against smoking, to reduce the use of tobacco in order to prevent our children to start smoking, to prevent people to be exposed to smoke from tobacco. And I came into that group in 1988. We made up a proposal for legislation. We also provided what we had to the sitting government, who came into power in 1991. And our Minister of Health and Welfare, Bo Könberg, in 1992, on the Tobacco-Free Day, we thought he will make a proposal to Parliament about legislation in order to reduce smoking, to get more smoke-free workplaces, and so on and so forth. He came to us and he said, I'm sorry, there will be no proposal. There is no opinion, no pressure from society to have such a legislation. Then we said, we have to start this pressure. And then Physicians Against Smoking was established, Nurses Against Smoking, Teachers Against Smoking, Journalists Against Smoking, Pharmacists Against Smoking. And during the following year, made a hard pressure on all these 349 parliamentarians and said that, okay, look here, you have to show that you really are keen on promoting health in Swedish population. And journalists were very efficient here. Asked ministers to come to radio and television and tell how they stopped smoking. And this really had an effect on the government, the ministers. So 1 year later, that legislation was passed in Parliament. But we couldn't have done it without the very, very motivated women in Parliament and the pressure from the outside, that Swedish doctors, pharmacists, journalists, and so on woke up at the same time and made this pressure. The legislation was then strengthened, and we got smoke-free indoor restaurants about 10 years later. And now, what is the situation? Well, the parties agree on the tobacco convention about a smoke-free world, yes. But the means to get there is a disagreement. Then here is the freedom of people to decide about their own lifestyles has become very strong. And also that so few Swedes smoke. I mean, today the figures are down to 7-8% without a strengthening of the legislation that we got in the early 1990s and this on indoor smoking in restaurants. So the saying is, well, why should we do anything about the legislation? Why should we politicians do anything? Because it's going in the right direction without any new activities from government. And of course, this is rather sad because I see the question now is smoking in outdoor restaurants. And there are asthmatic children, youngsters who can't go to these restaurants, and also from those who work there in these restaurants, they complain about the environment because smoke doesn't just fly well like this. Outdoor restaurants here have the ceiling, they have walls, and it can be rather intense here. So that's what I wanted to say as a start. Thank you.
Thank you. Thank you very much. Now, I think we have Mike. Hi,
Hello.
Mike. Can you hear us?
I can hear you. Can you hear me?
We can hear you.
Splendid.
Splendid. Professor Mike Kelly, wave to the audience, is from the University of Cambridge Department of Public Health and Primary Care and former director of Centre for Public Health at UK's National Institute of Health and Care Excellence. He is a sociologist and an economist, and he claims that telling people about risks doesn't help much. It's all in the science. Welcome, Professor Mike Kelly.
Thank you. Well, good afternoon, everybody, and it's a great pleasure to be with you. And it's a matter of some regret that I can't be there in person. So I'm going to talk to you about some of the lessons learned in the United Kingdom over the years, and to try to get to grips with this thorny problem of the extent to which smoking is a matter of individual choice and an individual freedom, and the role of government. So first slide, please. Now, we've already heard mention of Professor Doll, Richard Doll, and his collaborator, Austin Bradford Hill, who as early as 1950 had published papers linking lung cancer to smoking. And by 1952, the physician study that was mentioned earlier was underway, and the early evidence made it quite clear that there was a very strong association. By 1964, that evidence was as concrete as it could be, really. We saw in that year the publication by the Royal College of Physicians in London and by the Surgeon General in the United States of two major reports linking absolutely the connection between cigarette smoking, exposure to cigarette smoke, and not only lung cancer, but a range of other serious illnesses. Now, what that science showed us, I think, was clearly that smoking was a risk to health. That was well established by the mid-1960s. However, this generated what is sometimes called the risk factor approach to cigarette smoking. I should have said next slide, please. The risk factor approach to prevention. In other words, the argument is that you've identified the risk, in this case, exposure to cigarette smoke, and therefore the answer is very clear. You focus on the individual and on individual level behavior change. And that, of course, was the response, not just in the United Kingdom, but in the United States and many other jurisdictions around the world, was to talk in terms of health education, discussion of the nature of the illnesses linked to cigarette smoking, and that kind of thing. The assumption being that if people were aware of the risk, they would reorient their behavior accordingly. They would change. Now, there was some evidence that that might be true. We've already heard mention of the physician study, and doctors en masse, more or less, began to give up smoking in the 1950s and 1960s, and some of the early evidence demonstrating these links came from those studies. However, other professions and other professional groups, at least in the United Kingdom, were not as quick to change their behavior. And indeed, although the risks were well known in the United Kingdom, certainly by the early 1970s across the population, change didn't follow in its wake. Next slide, please. Now, the important thing to bear in mind is this, that focusing on the risk tells you what you need to do, which is, of course, to reduce the risk. But here's the important point. Knowing about the risk, whether you're a doctor, a planner, a politician, or indeed a smoker, doesn't tell you how to do it, how to make that change. That's a separate science. So where we start with, by understanding risk, is biomedical science and epidemiology. But in order to change things, we have to look to other branches of science to help us to do so. And it took quite a while before that important way of thinking seeped its way into government in the UK, for example. Next slide, please. So understanding the etiology, the causes of lung cancer or emphysema or coronary heart disease doesn't explain how to do the prevention. Etiology and prevention are separate scientific things we need to do. This is a very important part of the way that we've moved things on with tobacco control around the world since those early days. Next slide, please. Understanding how to make these changes comes from the evidence, from a broad evidence base, including psychology, sociology, anthropology, economics, and political science. And to give you some examples, the understanding of the price mechanism, the way that affects consumption, that comes from the discipline of economics. Understanding the nature of addiction comes from the science of psychology. Understanding the way that peer group pressure can both reinforce people's smoking habits or indeed the reverse, can help them understand or to see smoking as an unfashionable or not cool thing to do. That evidence comes from sociology. And indeed, the understanding of how to get governments to change their minds, that's derived from political science. Now, one of the big mistakes which was made early on was the assumption that once we know that smoking is risky, it's simply a matter of getting the message out to people, whether they're politicians, whether they're the government, whether they are smokers. If we could only get the message out, things would change. But it didn't at first. Smoking rates didn't begin to move very quickly. They did begin to move, but they didn't begin to move very quickly just on the basis of information. It was when we drew into the evidence base from these other sciences that things began to change. We began to be able to do things properly. So smoking cessation programs, for example, quit programs, rely upon the scientific base drawn from the social sciences rather than from the medical sciences. Next slide, please. Furthermore, one of the other clear things that's emerged is that successful tobacco control involves a multi-level, multi-sector approach. It's not one actor in the situation that will make a difference. It's not the single smoker. It's not the single politician, but it's multi-level across government. It involves the private sector, the public sector. It involves individuals. It involves schools. It involves non-governmental organizations. It's something which has to be done in concert. And it really took several decades before all of these agencies were working in the same kind of direction. And that's because we need to focus on things like price, advertising. I can remember as a child going to the cinema, and not only were all the film stars smoking during the films, during the interval there were advertisements for all sorts of cigarette products. And of course, the cinema itself was full up with smoke. And as you saw the beam coming from the projector, you saw the smoke wafting upwards up to the ceiling of the cinema. Health education is important. we do need to educate people about the risks, and we need to continue to do that. It's not something that once and for all, once people know something and then they change. It's something that has to be continuous. It's an ongoing process. Quitting support is terribly important. There are different methods for doing that these days. We can do it on a face-to-face basis, brief interventions, that kind of thing. And as was mentioned in, I think, the first presentation, the role of physicians reminding smokers when they see them, every time they see them, are they smoking? Have they thought about quitting? And that kind of thing is a very important message to give out in that. Availability, how easy it is to buy, as well as, of course, normative cultural change. It's very interesting as I reflect now at the end of my career on what it was like at the beginning. When I was a young student, when I went to university, there were ashtrays in every lecture room. Students were encouraged to smoke during lectures. The lecturers smoked. It was a smoke-rich environment. And I actually grew up in a household where all my adult relatives smoked, all my neighbours smoked. If I got on a bus, everyone was smoking. Smoke was everywhere. Now, of course, when I look around here in the UK, where we've had a ban on smoking effectively in all public places, we live in an almost completely smoke-free environment. If you go into a supermarket, you can't see cigarettes. They're hidden away, and you have to go away if you want them and buy them specially. We've seen a real normative cultural change in that regard, where if we were to see someone light up a cigarette in a pub or a restaurant, it would be a cause for shock or alarm. And of course, when I used to travel abroad anyway, it used to come as a surprise to me, be somewhere and I'd see people smoking in indoor locations. It seemed very odd. You get used to the smoke-free environment very, very quickly. The NICE guidelines that I was responsible for in the years I worked with them from 2005 to 2014 were about different parts of the multi-level approach. We did guidelines for children, we did guidelines for schools, we did guidelines on smoke-free environments, as well as on the construction of smoking cessation services. The idea was to work across this whole gamut of things, all the different actors that are involved. But it's important to bear this in mind. Efforts to bring about health-related behaviour change must be evidence-based. It's no good relying on common sense. It's no good relying on saying, well, let's get the message across, this kind of thing. We need to look to the sciences, including the social sciences, if we are to succeed in doing this. And this is true whether we're talking about individual level behaviour change or governmental level behaviour change. At the individual level, we're dealing with science, not common sense. Next slide, please. Now, there are some very, very powerful theories of health-related behaviour change. And I've mentioned just one, which is called the COMB model, COMB model, which is associated with the work of Susan Mickey, the Professor of Health Psychology at University College in London. And the really powerful thing about this particular approach is that it recognises that individual level change is based on three things: the competence or the capability to make the change. We need to give people skills if they're going to make changes at the individual level. But it's also about opportunity. We tend to make changes when the opportunity arises. And if the opportunity doesn't arise, we tend not to. And of course, one of the greatest things we've seen in recent years in the United Kingdom is the fact that the opportunities to smoke in public places has all but gone away. And of course, motivation. If people are to make changes, they need to be motivated to do so. And they need to be motivated and want to do it. And those three things together are at the heart of successful individual level behaviour change. So it's not about telling people what to do. That change has to come from within them, not from external sources. But there's also an evidence base at the social level too. We understand from the political sciences, from the sociological and anthropological sciences, about the dynamics of the way these things operate at the political level, at the social level. And we must bring that evidence base into play too, if we are to make these changes, which are so beneficial for the health of the population. Tobacco remains not only one of the leading causes of death worldwide, But in the United Kingdom and in the United States, it is the underlying reason for the patterning of health inequalities across both of those societies. And we see this emerging elsewhere. The problem with tobacco hasn't gone away, and neither will it go away. Tobacco, or the nicotine in it, is one of the most addictive things known to mankind. So it's something where the fight must go on. We've made huge progress over the years, but we need to continue to be vigilant and need to continue to, in our efforts at the individual and at the social level, to reduce the risk associated with tobacco exposure. And I'll finish on that point. Thank you very much for listening.
Thank you, Mike. Our last but not least speaker is a professor of practical philosophy here in Uppsala, whose research have focused on issues related to national versus global governance and democracy. Please welcome Professor Folke Tersman.
Hello. It was fascinating for me to listen to these three talks ahead of mine. But I will try to be a little bit briefer. So I think I was brought here to criticize governmental interventions in people's lifestyle choices on anti-paternalistic grounds. But I'm not going to do that because I don't believe in that sort of criticism at all. I think governments have an obligation to induce lifestyle changes, such as those related to smoking, for example. And this anti-paternalism argument is also not decisive in this context, of course, because we can justify those interventions also with reference to harms to others besides those the subjects, the smokers themselves, and so on. So what I want to talk about is another thing that I'm sometimes worried about concerning how governments address health risks. In my opinion, and this is kind of my message that I want to put forward, it's important that governments, when communicating about health risks and when taking other types of measures, act in a way which is proportional to the current state of the evidence. They should not apply some sort of 51/100 strategy, such that if the evidence justifies, just the conclusion that the proposition is more likely to be true than not, then we should still act on it with 100% confidence. That's not a good strategy, I think. We should have proportionality. And this is not a problem in the case of smoking, of course, as the evidence is so overwhelming. So it's not a problem there, but it is a problem, I think, with other health risks or alleged health risks. Certain types of diets, perhaps, or foods, or other tobacco products. So I'm going to take an example that is very familiar to most of you, perhaps all of you, but Swedish snus. Snuff isn't really the proper translation, I think, but it's a very different substance from other types of smokeless tobacco. So at the back of this little box, it says, this product is harming your health. And that's a vague and, in my view, questionable statement. So I think we can all agree that snus improves your health if it helps you stop smoking. And it has helped a lot of people smoking, according to many scientists, which, according to these scientists, contributes to explaining why the prevalence of smoking in Sweden is so low. And there are studies suggesting that snus offers some protection against Parkinson's disease. There are other studies suggesting relatively weak correlations with different forms of cancer, cardiovascular disease, and so on. But yet further studies have not been able to find any much support for those correlations. So quite a lot of research has been done. And since many people have done this for a long time in Sweden, there is a lot of data. And it's nevertheless fair to say, I think, that the evidentiary basis, the current evidentiary basis, is quite ambiguous and inconclusive. So a more adequate text here would perhaps be snus may cause may harm your health, which is exactly what it said a few years back. So the government has changed here. So we can discuss this particular example, but I want to make a general point. And the point I want to make is that the problem with not respecting this proportionality constraint is that it threatens to undermine people's faith in the governmental recommendations and institutions quite generally, and perhaps even, medical science. And this in turn risks reducing the impact also of recommendations and so on that are well supported by evidence, such as in the case of smoking. I mean, this is also an issue that needs to be studied more, actually, along the lines that Mike talked about by sociologists and so on, but still there is this risk. Also, all of us in here, I'm sure, are worried about the post-truth and fact resistance phenomena, and all of us probably think that scientific norms should be given a more central role in the public debate. But then it's also important to make sure that when actors appeal to science, they get it right and uphold those norms, according to those norms, and do not overstate conclusions, the conclusions scientists reach. What they can do is instead to be more upfront about the reasoning behind the recommendations and the evidence, and also point to methodological problems, for example, in the case of diets. And so on. So what we need, I think, is more science rather than less, in the sense that we also talk about the reasoning that leads to a recommendation. Also in these contexts, maybe with very small letters at least, if we have to elaborate. So how should we do this? I think we should insist that this proportionality principle should be stressed in the instructions given to the agencies of the relevant kind. And we should also insist, I think, that people with significant research training are employed at all levels in those organizations. I only know about the Swedish context, so we can talk about other contexts. And that includes the communication offices, actually, the people who actually articulate recommendations or information that goes out to the public. And working towards that end, I think, is an important task of the scientific community, and something that needs to be pursued actively and continuously, for example, through its learned academies, or why not a conference like this one. So thank you very much.
Did you comment? Thank you, Folke. First, do you have any comments on what has been said? Vinayak, Barbro, and Mike is with us. Do you hear us, Mike?
Yes, I do. Can you hear me?
Yes, I do.
Thank you.
Barbro, the snus question.
Well,
it's healthy if you stop smoking.
but snus carries other risks, and I think the population and the politicians here get different descriptions of the scientific status today, and as long as you get these different pictures, you close your ears, and especially politicians, as long as scientists don't agree and we get these different evaluations, we do nothing. And therefore it's so important to have a governmental agency like the one we have in Sweden for public health, who evaluates the data as long as they come. Unfortunately, in Sweden, there was a move of this governmental agency outside Stockholm, so they lost a number of their most qualified staff. So it has taken some time to build up that competence again. But I think there is a strong need in Sweden of having a scientifically based governmental agency for public health, continuously evaluating the data which come and get the politicians and the public to to believe in this governmental agency, that they really have the competence.
Vinayak.
So this harm reduction debate is quite interesting. Well, our WHO's position is all forms of tobacco is harmful. But in the US, now more youth use vaping devices, the electronic nicotine delivery systems. And the argument, and again in the UK, and Mike can correct me, is again a conscious policy of the government to encourage moving towards electronic cigarettes.
So isn't that good? Better?
But that's the point. The point is that are we keeping the addiction alive in a society? And then new evidence, which is pointing that a number of these users move to conventional cigarettes at a later point of time. So why are we keeping the nicotine addiction alive? So Finland, for example, wants to go the other way around. Tobacco-free, nicotine-free. And so again, there are different practices, but ultimately it's the societal norms, whether we want to remove tobacco and nicotine from society or have the risk of another generation struggling with tobacco. That's a policy choice.
Would you like a total nicotine-free society?
Yeah.
That's the ultimate goal, and the governments are agreeing to a 30% reduction over 15 years. The total number of smokers is still stable, 1.1 billion for the last 17 years. Only the percentage is going down slowly. We need to continue at that path so that in the next 30 years, we have less than 5% of the world into tobacco.
If you want to get in, Mike, you wave, huh?
Okay, yes,
Oh.
I'm waiting.
Sam får du vifta om.
So, I thought emerging out of the discussion, there are 2 or 3 points that we might want to explore. The first relates to Folke's presentation. And I think it's really important. A number of the things he said are really, really important. But something I'd like to bring out is the difference between absolute and relative risk. One of the problems we have, I think, globally, certainly a problem in the United Kingdom, is that most journalists are unable to distinguish between the concept of absolute and relative risk, or rather, when they write their stories or make their presentations, they don't make it clear. Now, this is interesting when you get to something like alcohol, for example. There is clear, I'll use a different example, smoked meat. You'll remember perhaps a couple of years ago that IARC, I think it was, put out a report which identified certain types of smoked pork, particularly bacon, as a carcinogen. Now, actually, technically, that's correct, it is. So the next day in the United Kingdom, papers were full of stories about bacon being the same as tobacco, about don't eat any fried bacon or pork sausages or anything like this. Now, actually, the problem or the confusion arose between what I guess Folke would have called proportionality, is the actual level of risk in absolute terms. You'd have to consume, if you compare someone who had consumed smoked bacon every day of their life from their birth to the age of 65, you had 100 people who'd done that, and 100 people who had never ever eaten smoked bacon at all, ever in their life at the age of 65. In the group who'd never eaten bacon of any kind, there would be 4 cancer deaths. And among the group who'd eaten bacon every day, there would be 5 out of 100. So the difference between the two is marginal. So technically, scientifically, there is an absolute risk, but it's very small, and that's important. So when trying to have these conversations about absolute and relative risk, it'd be really, really helpful if both scientific agencies, governments, politicians, journalists, and scientists, because sometimes scientists are the worst offenders here. What they do in order to get their stories into their recently published papers in the newspapers, they tend to over-egg the argument. And relative risk, which always sounds much, much higher than absolute risk, is a much better way of doing it. So that's one really important arena where I think we could work together to do it.
Thank you.
Second, okay, I'll come back to the uncertainty thing later.
You're going to come back. Folke now.
Yes, I would like to say a few things, 2 things basically. I mean, I'm not against a decision to the effect that we have a nicotine-free society. Perhaps that's a good idea, but we should nevertheless be upfront about the current state of the evidence, even if we believe that being upfront is going to make it more difficult to achieve that aim. I think we should not be strategic here and present evidence from a pragmatic point of view so that we can change people's views if the evidence presentation is not accurate. I mean, Barbro said something about disagreements. Politicians don't listen to disagreeing scientists. I think disagreement in a scientific community is a very important phenomenon. We shouldn't try to push that or shove that under the carpet. I mean, take, for example, the agreement that exists today in the case of climate change. I mean, we are all very impressed by the fact that only a few outliers now question the science. We are very impressed by that, rightly, I think. We should also be impressed by the fact that there's a lot of disagreement about some issue. That means something, I think. So we should be clearer about separating evidence from the types of measures we want to take.
But that might not make politicians to decide things within the next few years, Barbro.
Politicians take decisions on the basis of the knowledge they have, but also about the values based on sort of a stomach thinking, not based on the values. You can see that in the area of assisted pregnancy, for instance, or questions concerning end of life, and so on. And therefore, when there is a disagreement and scientists argue who is right, who is wrong, at the same time, well, then I can wait until they agree, because I have 1,000 questions as a politician in the air, and then I make priority to those where I'm rather confident that this is a route we are going to go.
Vinayak and then Mike, okay?
So it's important, the evidence is all there. I mentioned there's only one treaty in the whole of health sector, it's tobacco. The evidence is there, nobody is questioning it. It's about the political will, which then matters. And to create a political will, better is how to get the society to be demanding it. So we need to create that social norm. That becomes important in the evidence-based treaty.
Short, Barbro, because I'm going to let Mike in then.
Yes, and that was what we reached in 1992-93, when the whole society actually pressed the politicians to get this legislation, but it's not there now.
Yeah, and it's Sweden. It's not many parts of the world. Yes, Mike.
Well, I wanted to pick up on a couple of things that came out there in that last interchange. And it was something I was acutely aware of when I worked at NICE, because NICE sits at the interface between science on the one hand and effectively politics on the other, and the profession as a third arm. But what one becomes very clearly available is that science and politics operate with very different standards of decision making. It's not that one is better than the other, they are different. Politicians, I think one has to acknowledge, have a really tough job. It's not a very pleasant environment sometimes in which to work, and they have to make decisions quickly and in the face of often uncertain knowledge and limited knowledge and limited evidence. Scientists, on the other hand, work on much longer time frames than most political decisions are made. Scientific research takes a long time. But at the end of most scientific research, we're often still uncertain about the meaning of what we've got. And as Folke rightly said, uncertainty and disagreement are the lifeblood of science. That's how it makes progress. Yeah. Now, trying to explain that you're scientifically uncertain about something, but on balance, you think the interpretation of the evidence is X, Y, or Z, rather than A, B, and C. That's what most of us who practice science spend our time doing. But that's a very difficult thing to transfer over to the world of politics, where you have to make quick and swift decisions. So what all of us need to get better at, I suppose, is talking to each other. and understanding the difficulties and constraints under which scientists work, under which politicians work, under which policymakers work. And we might get a bit better at dealing with some of these, what are really quite tricky problems of decision making in the face of uncertainty, or in the face of evidence that is equivocal in various kinds of ways, or in the face of making difficult interpretations. And, you know, it's always been like that in public health. Even when we go back to the early smoking stuff, Dolan-Hill's original work was correlational and associational. It was only the causal stuff that came later. And I suppose my argument was, certainly when I'm teaching my students, we need evidence from correlation and association, but we also need evidence of mechanisms if we'd have a true understanding of the nature of causation.
Thank you. Folke.
Yes, I talked to one of the world's leading climatologists yesterday, actually, and who has been seriously involved in the IPCC work. And he talked about how the IPCC had been, to some extent, influenced by these ideas that we need to adapt to what is politically feasible in presenting our data, our theories, and our evidence. We can't just say, write out how the situation is, because it's not going to lead to any political action if we do that. Today, these people regret that a lot. They regret taking such consideration, having taken such consideration before. It didn't lead to what they expected. It just they now see it as that it just led to a situation which is much worse than it could have been. Sorry, you were saying?
Finish.
So I think, you know, scientists are good at being scientists. They shouldn't speculate about things that they are not experts about, such as how do we influence politicians, for example, or how do we influence the public.
But don't you have a responsibility to explain at least your science to the politicians so they understand in a way? It might be a sort of lack of communication here.
Yes, but I think you shouldn't underestimate the politicians, actually. Maybe that's your... I think you shouldn't underestimate people in general either. I think they can listen to a scientist saying, we're not entirely sure, this is the evidence, these are the problems, but I think we should still do something about this. I think the general public understands that sort of reasoning.
Okay, I want to get back to tobacco control and the tobacco industry, Vinayak, that you started to talk about. Talking about politics, you said. I do politics with the tobacco industry every day. How do you solve this problem of the economy and all this to make people to continue smoke?
So that's a good question. Tobacco industry tactics are similar anywhere we go in any part of the world, whether it's big tobacco, whether Philip Morris, BAT, or it's the small tobacco companies. The tactics is to keep the addiction alive and somehow convince the government that it's good for the economy. 80 countries grow tobacco crops. And then it's good for the economy in terms of tax. But when you look at the total numbers, what do we get? $400 million of tax against $1.5 billion of cost. So there's a huge loss to society, except perhaps, as I said, Malawi, which has more than 10% of their economy, and Zimbabwe at 5%. No other economy is actually benefiting. They're actually losing out on the health cost. And the industry arguments fall flat there. But the industry is reinvented. They're looking to launch new products on a regular basis now, and confusing the governments and the public.
So
they
there
need to be
it's
aware.
impossible to do governance because the tobacco industry is stronger than the politics in a way.
No, we have huge commitments. There are many countries showing that they can tackle the industry. We need to be watchful and extremely careful when we talk to the industry.
Your comments on that?
Yes, of course. Tobacco industry is lobbying us in Parliament, and I think all over the world to a great extent. And then it depends on which lobbyists are you going to meet, because you have to make a priority. Of course, I don't meet them because I meet others from which I know I will learn something else, because lobbyists also can present useful facts. It depends on the question. But tobacco industry gets a lot of time from politicians on a whole, I know.
But what is actually the most realistic idea to make people stop smoking then? Would you say? Should you ban tobacco, for example? Is that an idea?
I think in a country like Sweden, it's not possible because smoking has gone down so much without
Vinayak.
any sort of punishment, or limitations, and especially not right before an election.
Oh no, that's not going to be popular.
So some countries are starting to look at tobacco-free generations, the future generations, make it more difficult to take tobacco, make it unpopular, make it uncool. So it's expensive, it's not cool. And I think that's, in one generation, we could see a huge shift in a number of countries. New Zealand is headed towards that direction. Singapore is headed towards that direction. We could see many countries here as well headed in that direction, like Finland.
Super short, because
Well, what we have to do is to reach the groups who are the real smokers, and there's different between different parts of the Swedish population. Young girls, young people with very short education, while the well-educated, they don't smoke.
Folke?
I just thought it was interesting to note. I mean, you mentioned the tobacco industry and that we need collaboration at the global level to kind of neutralize that. And that's just one of very many examples of cases, or shall I say, arguments for having stronger supranational political structures. So it's interesting to see how this question pops up in so many different fields and areas.
So Mike, if you would give your best advices to a government to make people change their health behavior, in short, what would that be?
Well, I think the tobacco industry question is important. They work very, very hard to undermine the evidence, to create doubt. That needs to be corrected. We need to be constantly vigilant against all the tricks of the industry. So that would be part of my advice. But second, I don't think banning is going to work. We found, as we raised price of tobacco in the UK, what we saw was a rapid increase in illegal tobacco trade. Finally, I'd say go back to that thing that I mentioned in my talk: multi-level, multi-sector working across society, and honesty about our understanding of the evidence.
Thank you very much. I want to ask the panel, what is a healthy lifestyle, actually? What would you say it would include, for example? Other than not smoking, I mean.
Well, I can't say any, I think, original things about that. Having a
non-original thing, you can
having
say.
Close relations,
okay,
a sense
close
of meaning in your life.
Yes, what more could you do to have a healthy lifestyle?
Less alcohol, healthy food.
Okay, what about you?
To feel needed, to be someone in society, and then be able to work as long as you want to do, or and also use all the advices on not causing falls. I mean, physical and so on and so forth.
What would you say? What about exercise? Is that a good thing?
Yes, among other things.
Among other things, exercise is a good thing. We will have that thought in our minds. First, we will give you a big applause. Thank you, Mike. Thank you, Folke.